Good morning, everybody. It's a pleasure to be here in front of all of you, and I'll try to make things simple, so that it can be easily emulated in the OR. To go ahead with the first thing is basically the iris repair procedures are divided. I consider them to be a pupil-centric or the iris-based repair. So these are the two ways that I usually divide the iris repair procedures that we need to adopt to perform in our ORs. Iridodialysis repair, when we fix up the iris base, many times what happens is we get withdrawal of the pupil on that side because there is correctopia, because maybe you have taken too much of iris tissue in the needle. So many times you have to combine it with a pupil-centric method. That is, either you do a single pass or a modified Siepsers or a MAC canal or whatever you are comfortable with. So many times it happens that we need a combination of the surgical procedures to be adopted to achieve a good centric pupil central method. So going ahead with this, I'm just showing a very simple case. This is the first case that I'm trying to show you. This is a referred case. The surgeon had performed phacoemulsification, and there was a chafing out there because probably it got embedded into the phacoemulsification probe, and this is how it happened. The patient had a lot of photophobia. So this is a very simple thing to do here, is to do a single pass 4-throw pupilloplasty procedure. But before I start saying this, you need to analyze the margins of that hole. There is a lot of loss of thickness of the iris tissue there, and there's a lot of chafing. So if you pass your needle through that area, it is going to give way during the surgical procedure. So you need to avoid that area and take the healthy amount of iris tissue. Now, another flip point of this is that if you take too much of iris tissue, then you might even cause a lot of compression of the iris coming up from all the sides. So you need a perfect calibration how to go ahead with that. Having done this surgical procedure, coming up to the basics of single pass, we passed. You can take a 9-0 or a 10-0 polypropylene suture. It's a long suture. It's a long needle with a suture which is available in the market. You need that to perform this pupilloplasty procedure. So that is what is available in our country as of now. Now, when we go through the proximal and the distal portion of the iris tissue, when we take up through that and you withdraw the loop till that point of time, it is similar to a modified Siepsers. But the difference that happens in a single pass is that you do not have to take the pass again, because usually we take sutures like you take a 3-throw, then you take 1-throw. That is what we consider to be a knot. But that's not the case with a single pass. Now, picking up this position, the loop has been withdrawn and the suture end. You can cut off this needle, but I don't want to sacrifice my suture at this point of time, because I know that with this single suture I will be able to close down all the iris defect that is present there. So I'm not chopping off the needle from there. I'm still keeping it, but I'm trying to pass that needle through the loop 4 times. When it passes through the loop 4 times, you just pull both the suture ends. It beautifully glides inside and it approximates the iris tissue, provided you have not embedded any corneal lamellar fibers into your needle. So that is a very crucial point, and that is, I think, what Dr. Ashwin was trying to highlight in his procedure. So yeah, this is a very technical point. When you pass the needle through the paracentesis, no corneal tissue fiber should come up to it. So you keep on doing this single pass 4-throw till you close the entire iris defect. So this is a simple thing. I move on to the next thing. That is a twofold technique, which now I'm trying to show you, which we published in the Journal of Cataract and Refractive Surgery. It is a non-appositional repair with a pupilloplasty procedure. So this is just an animation that describes the procedure. So this is an iridodialysis repair that is going on. This is a traditional non-appositional repair described by Dr. Snyder. What you need here is a double arm suture, and you fix up the iris base. And as I said before, whenever you do that, many times you have that withdrawal of the pupil coming up on the side where you have done a repair. So whenever you get that, you need to close it, because otherwise you have an eccentric pupil in the postoperative period. To avoid that, we usually combine it with the pupil-centric method, whichever method you are doing. Here I am doing a single pass, so you close down that defect and then it looks cosmetically as well as functionally good. That's the most important aspect of doing a pupil repair. So these are some of the crazy cases, that we take up during the surgical procedure. Having done the basics, we can go ahead further. This was a case, and this was a traumatic cataract with a very massive severe iridodialysis. I'm going to show you a recent case that I did with one of the most recent methods that we have adopted. Now this is a traumatic, again a referred case, a traumatic cataract. This is the trocar anterior chamber maintainer. I'm using this for fluid infusion inside the eye. I have put triamcinolone also to detect if there is any vitreous inside, because this patient was a pseudophakic patient, but somewhere down the line I did feel that maybe there might be some vitreous tricking in, but fortunately it was not there. So what I decided was that, okay, now I just have to do a pupil repair procedure for this patient. So we have done a peritomy, and this is the scleral groove that is made along the entire length of the iridodialysis repair that we actually want to do. And now I am trying to flatten up the iris tissue. That is very important that we need to do, because it's just curled up. So you need to flatten it out to see that how much iris tissue is available and how much you are going to take up into your needle to fix it to the sclera. So this is the trocar assisted iridodialysis repair. I have removed the fluid infusion now. Instead, I'm using a viscoelastic now, and I'm using that trocar which was placed to pass my double arm suture for an iridodialysis repair, because this takes away my headache of accidentally getting those corneal fibers into my needle, and I don't want it, because then I will have to redo it because the suture is not going to slide inside. So this is the trocar assisted repair. The double arm suture, now what you can see is flipping inside, and moment you pull it from both the sides, you have that iris tissue coming up to the base. But yes, again, when you take up the sutures, again you need to do a bit of calibration, trying to oppose it to the sclera, but not pulling it too much also. But still, in spite of doing these things many times, we still have that correctopia kind of a thing coming up. So as explained before, the trocar, you can pivot it almost like it gives you an SS of about maybe 100-120 degrees of iridodialysis. You can easily correct with placement of one trocar out there. So this is again the same procedure being done. You keep on doing it till you are done with the iridodialysis. Maybe you might need to do it once or twice or thrice. It all depends upon the degree of the iridodialysis that you actually have. The only point that I want to say is that you need to get those sutures into the groove. That is where you are going to bury it. Well, now I had coupled this procedure with a reverse fourth row pupilloplasty, which I will showcase in my next animation, that how we do this procedure. This is exactly the reverse of a single pass fourth row. The needle, it enters the iris tissue from behind and it comes up anteriorly from both the sides. So your suture track is like that. So only thing that makes a difference here is that in the post-operative period, you do not see those suture knots on the anterior surface of the iris. You actually do not see. It's like a plastic surgery that you have done for your patient. There are no sutures to be seen. Actually, many times, even if you see these patients in the post-op period, if nobody tells you, you will not even come to know that pupil repair has been done for this patient. So it works beautifully like that. The knot goes behind the iris tissue. Otherwise, the entire surgical procedure is the same as a single pass. But yes, it's a bit technical challenging because you need to pass the needle from behind. So you need to be a bit more of an ambidextrous, and you need to have a little bit of flexible iris tissue out there to do the procedure. So anyway, this is what I was trying to highlight. You need to bury those knots into the scleral groove, and you need to rotate them as we do it with the corneal sutures, and then you can just seal off the peritomy with whatever. If you have a glue, you don't have a glue, it's fine. We can just do a cautery and you are just almost done with that. So this was about that. Application, Urette-Zavalia syndrome, a persistently dilated pupil. I think many of us, not very often, but yes, occasionally we do come across. You have done a perfect surgery and you come out of the OR, but the next day you see your patient has a persistent dilated pupil for no reason, does not respond to miotics. That's a Urette-Zavalia syndrome. the pupil remains into that position forever. And I had this patient because the surgeon had done a very beautiful surgery for that, and it was a premium IOL, but patient was not happy because there was so much of glare. I'll show up that video. What actually happens is there, you can see it. It has been reported after phacoemulsification, after penetrating keratoplasties, after DALK procedures, many times even after YAG also. The pupil goes into a dilated phase. It causes peripheral anterior synechia with a raised intraocular pressure. And what solves it is a pupil repair, because what you have to do, you just have to bring the iris into the center, but it has to be done as a timely procedure, not when everything is scarred in the periphery and then you have nothing left with you. It won't work then. So the timely intervention is very important. In case if you have a patient like this, what I'm trying to show you now, please understand it's a Urey-Zavalia syndrome, and no amount of pilocarpine is going to work for this patient, because the pupil is not going to respond. Now this was a premium IOL patient which was referred to me. This was a lady. She was constantly complaining. She had raised intraocular pressure around 40, 45. Nothing was working for her. So I took her up surgery. Maybe it was about 1.5 months after the original surgery that had been done by the surgeon. And what I'm trying to do now was I was trying to assess the flexibility of the iris tissue, because the iris tissue has remained like that for maybe 1.5 months like that. So we need to just see how much flexible it is, and then we need to gauge how much amount of the iris tissue we are going to take up into the suture needle. So this was a case where I am doing a single pass 4-throw pupilloplasty procedure for this patient. As previously explained, you have to take 4 throws going all along in a single direction, and if you forget to count, you can take 1 or 2 throws extra. Nothing matters if it is 5 or 6 throws, but it should not be less than 4. If it is less than 4, it is going to open up. When you slide, it will go inside, and when you will cut up, it will just open up. So in order to avoid that, you have to take an optimal 4 throws. If it's more than that, makes no difference. It just adds to the bulk of the suture inside, but then it's safe. So this is single pass which I'm trying to do on the other side too. We have actually developed a nomogram for this, like, depending upon the type of the peripheral anterior synechias, the amount of synechias that you have in the periphery, you might have to do it even thrice. That's a 6-point traction. But this patient, it was a fresh case, so I just decided that, okay, I'm just going to close down the pupil from 2 sides. And actually this patient responded very well in the post-operative period. There was nothing else that I had to do for this case. Immediately the intraocular pressure went off. I did not give steroids to this patient. Post-operatively, it was on the non-steroidal anti-inflammatory drugs that I had kept the patient, but she responded very well. So, but the point is that, we need to diagnose this, that, okay, this is Urey-Zavalia. This may be. You can wait and watch with your treatment, but if it doesn't work, you should consider doing this procedure. So, this is how you just go in and you take up a micro scissors and you cut up the suture from both the sides. But when you cut up the sutures, these are some of the finer nuances of this surgical procedure. When you are cutting up the sutures, you have to be very careful, and you just pull this. Many times we feel we have cut the suture, it has not cut, and it has happened to me also. I just pulled it off like this, and what happened was, in a hurry, I created an iododialysis because I thought I have cut the suture, and I pulled it and it was not cut. So I just pulled it and it went off. So then I had to do an additional iododialysis, not for this case, for another case, but yes, it can happen. So you have to be very careful when you're just even taking off those small sutures from both the sides. The other applications that have been described for the single pass is for the endothelial keratoplasty procedures, as it was previously explained by Dr. Rashwan. I'm not going much more into detail because you do not have those actual knots coming up into the anterior chamber. It almost lies flat. It helps in compartmentalization. What I actually want to show you is the reverse 4-throw technique, which recently I had described last year in the European Journal, and how we go about it. Now this is the animation that describes the passage of the suture in a reverse 4-throw. This is exactly the opposite of what you have been seeing in the single pass 4-throw. Look at the way the needle is piercing the iris tissue. The needle pierces the iris tissue from the posterior to the anterior surface. And then you railroad this. So now your suture track, I will show you in the next animation how it is actually going inside the eye. So this The only difference is the way your needle pierces the iris tissue. So that makes all the difference while doing this surgical procedure. So you withdraw the loop outside the suture and is cut 4 throws, you go in, and when you cut it with a micro scissors, the knot goes behind. So this is the suture track. It's like doing a plastic surgery for your patient if you do this surgical procedure. This is the suture track. So when you are tying those 2 sutures, by pulling them, it goes behind. So, well, this is the clinical video. If you want to see this, I'm just highlighting how to pass on the suture. From one of the paracentesis incision, the 9-0 suture needle comes in, you hold it with an end opening forceps. You will need an end opening forceps here to hold it because the needle automatically doesn't go inside. So you have to hold it and then you have to pass the needle from behind. So this needle goes in there. Similarly, from the opposite side, you come in with a 26 gauge needle, again the same way, goes behind, comes in front, you railroad both together, and then actually, honestly speaking, single pass is more easy to do than this surgical procedure, because single pass, you know, you can just pass on like this, it goes with your movement. So that's fast and brisk, but this also works like if you really want to, you are in an advanced stage of iris repair, you can pick up the surgical procedure too. So this is like the suture thread has totally passed on, and then you're just withdrawing the suture loop. You can use a Sinski's hook or something, and you can pull up the suture thread outside. This is the loop that we call, and you have to pull up from the opposite side. It comes out through the paracentesis incision, and then comes the 4 throws. I'm going slow on this because if anybody is trying to learn, you know, they can just pick up some learning points from here. Because for me, there is no point rushing if nobody even picks up what I'm talking about. So these are the 4 throws. You know, you can watch them gradually going on in the same direction. 1, 2, 3, 4. You can count it loudly also. And then you just pull, it automatically slides. See, this is where comes the importance of not having a corneal fiber. Then only your suture will slide. If your needle had a corneal fiber, it will not slide. It will remain on one side. On one side, it will go inside, and on one side, it will not go inside. And if you pull it too much, instead of sliding inside, it will cause an iridodialysis on the opposite side. So be very careful with that. So this is the reverse knot, which just goes behind. You won't see anything in the anterior chamber. This is the anterior segment OCT, shows nothing. You will not be able to find it out even on an anterior segment OCT. So this is the suture knot that was for the SFT, but for the RFT, reverse 4 throw, it goes back like that. So these are some of the cases, you know, with RFT. That is what I said. It's like doing a plastic surgery. I have put up an arrow where the suture has been taken. In fact, Samir only saw my patient in the post-op and he said, "You didn't do any pupilloplasty. I'm not seeing any suture." I said, "No, I did a pupilloplasty." Even he could not make out on the slit lamp that, okay, the repair has been done. So this is, I don't know if I have time.
Please.
Yeah.
No, I think so.
I'll
I'll just wind up this fast. This is a flanged riveting technique. I'll just show the animation for this. This is one way of doing an iridodialysis repair. You can take a 6-0 proline suture, create a bulb with a low temperature cautery, and you know, this is a 30 gauge needle which is passed, and you can railroad that into that. You can pull it like this, as you see, cut off the extra suture and create a flange out there. The flanges should be big enough to hold the iris tissue. So this is a flanged riveting technique which was originally described by Japanese doctors. So this is how it actually works. If you do not have a low temp cautery, it is fine. Even if you have those ballpoint cauteries, they work very well. You can just heat them up and you can use them to create a flange. It works beautifully. So this is just a case. I'll just run through this to show you just a clinical case. Along the iridodialysis, the first thing is you do a peritomy, create a groove. If you don't want a groove, it's okay, fine, but you will have to create a Hoffman pocket because you need to have something to bury those sutures. You cannot leave those sutures just like that in the beneath the conjunctiva. So these are 2 options that you have here. It is associated with a traumatic cataract. So first the cataract extraction is to be done. Once you are done with that, then you go ahead with the iris repair. This is a small iridodialysis, so no iris hooks were used, but if it's a big, you need to use the hooks also to withdraw the iris tissue from that area, because you need to do phaco first. Anyway, this is 6 suture, proline, flange is being created. You can just see this, and then we just press this so that the flange becomes flat and it becomes much more wider, and so that it holds good amount of iris tissue along with that. So what is being done is, through the scleral groove, you pass a 30 gauge needle, and from the paracentesis incision, you just take that 6 proline, you glide into the lumen, and it works beautifully. So you need to, you can keep the anterior chamber stable all the time. Here there is no complication. You can very easily use an OVDs inside to have a deep anterior chamber. So you are just threading this suture into this needle. Nothing much is to be done. You just have to pull this out, and then you create a flange on this side. The only downside of this technique which I have found is that if your iris tissue is very friable, the flanges don't hold the iris onto its base. The flanges, they just give way many times. But if the iris tissue is healthy, it works brilliantly. Yeah, so it needs a good amount of healthy iris tissue to be there. If it's a friable kind of a thing, flanges are not going to work. They're just going to get out of it. So this is just like you are just approximating even the area next to it. You are imbibing it. Yeah. See, this is very important step. The amount of iris, that I always keep on saying this, whenever you are taking the iris tissue into the needle, you should know how much iris tissue you are taking into the needle, because the amount you take that is the amount that is going to be withdrawn. If it is too minimal, it gives way. If it is too much, it causes too much of correctopia. But it's very difficult to find out the exact balance of the amount that you actually need. But anyway, you need to know both the methods of doing a iris repair. That is, you need to know even an iridodialysis, and
Priya,
you even need to know the
conclude
pupil centric. Yeah. So you just create a flange, you cut this off, create a flange on this side, and it holds it beautifully into this position.